Hello, everybody, and welcome to today's CalMap and CAMP webinar on identifying and addressing anxiety in kids, youth, and young adults in the primary care setting. My name is Joanne Jung. I am a general pediatrician by training and also Senior Associate Director at CalMap. And I'd like to introduce my colleagues here, Dr. Petra Steinbuchel and Shelly Nakaishi, who also help to staff CalMap or have been close friends for a long time. As everybody is coming in, I'd like to welcome you just to drop into the chat your name, maybe what organization you work with, maybe what part of the state you're coming from, what county you're in, or what city you're in, just so we know who's here today. And then as you're doing that, I'd like to welcome, we're going to just watch a little bit of a video about CalMap so you know who we are and what it is that we do here. So with that, let's go ahead and get that video going.
Great. Nice to be with everybody. And I think maybe before we get into the video, thank you, Kat Schieffer, for introducing yourself from Ventura County, Teresa Davies from LA County, Natasha Sharma, Native American in Alameda, Rebecca Sponberg, welcome. And maybe we can just say a little bit more about ourselves and our work. So I'm Petra Steinbuchel. I'm a child psychiatrist and have been delivering care through Children's Hospital Oakland since 2007, and have worked closely with Shelly Nakaishi, who's a pediatric nurse practitioner for many years, and in different ways we've worked in integrated care settings throughout Children's Hospital Oakland network of care, including at school-based health centers and in primary care. And so I'm going to pass the mic to Shelly to say a little bit more about her background.
Hi, welcome everybody. This is dedication being here at 6 o'clock tonight for a webinar on anxiety. I am a pediatric nurse practitioner trained at UCSF in the MEPIN program that they had about 20 years ago. And the first job I had was in child psychiatry. So I'm trained as a pediatric nurse practitioner, but the psychiatrists and psychologists I work with really helped to train me and build my skill sets in being able to provide child psychiatry services, outpatient to mostly it is all Medi-Cal, from 3 up until 21 years old. But I also spent time in our pediatric primary care clinic doing like behavioral health integration and seeing our more mild to moderate young people and kind of help to build that program out. I also work in our school-based health clinic for a high school in Oakland, Castlemont, that I continue to see young people with their therapist. And we often also meet with the primary care provider too. So it's one, really collaborative, integrated team as well. And then I was one of the first people to get my pediatric primary care mental health specialist certification. It was free the first year. So I'm very lucky to have that. And yeah, I can thank Petra for helping me build my confidence in treating the very moderate to severe mental health needs. But I had to be trained because I came from pediatric primary care setting. So what I'm trying to really emphasize is that lucky me, I had that training and the support and consultation. And I know you have busy practices. But CalMap is now there for you to get consultation to kind of help hold you through learning this, because they provide the educational information, but they also provide the consultation to support you so you can build your confidence in treating mental health concerns in primary care. So that's a long way of saying you can do this. And I've been teaching now as a volunteer faculty and actually teach a lot of pediatricians and residents about, child psychiatry.
Great to be here with all of you. And thank you, everybody, for putting your name and information into the chat. I'm just signaling in the chat that we'll walk through the video about what CalMAP does and how it can be of support in addressing anxiety as well as other behavioral health conditions that show up for you in your practices. And then we have, some didactic that we'll share, but honestly, we would love to have this be, a rich discussion and invite you to enter questions into the chat. And we'll wait and save the questions, for addressing and discussing after the didactic part, because sometimes, the question that you have is going to be answered by the very next slide. But we really would welcome also any kind of consult questions that you have that may come up as you're hearing this. So, if you are able to engage, we would really, really welcome that. So, with that, we will share. This is just kind of a brief overview of what we do, and I feel like showing you this is a lot richer than just telling.
It is critical to address mental health because mental health is health. We, as primary care providers, cannot say we are caring for the health needs of our pediatric patients unless we're addressing mental health as well. And this is particularly true because a lot of these conditions, if left unaddressed, can completely derail a child's life trajectory.
I mean, we know that we do not have enough behavioral health providers, including child psychiatrists and even therapists across the state. And so CalMAP really helps bridge that gap.
What's great about the consultation service through CalMAP is that as a busy primary care clinician, we're often bouncing between patients, and being able to schedule a time that works in my practice has been really helpful. It's been really meaningful to initiate treatment earlier and not have to sit there and tell the patients that it's going to be months until they can see someone before they can get help.
CalMAP is here to support primary care clinicians throughout California in addressing the common mental and behavioral health concerns facing youth from infancy all the way to age 25. You can easily connect with child and adolescent psychiatrists, specialized psychologists, and care coordinators for real-time curbside consultations, as well as asynchronous e-consults. Getting started with CalMAP is quick and easy. After registering at calmap.org, you can request a free provider-to-provider consult online anytime or by calling 1-800-253-2103, Monday through Friday from 8:30 a.m. to 5 p.m. We'll connect you with a behavioral health specialist within 5 minutes or at the time of your choosing. CalMAP is a no-cost solution that also offers hundreds of clinical tools, resources, and continuing education eligible trainings designed to support your care for youth, mental, and behavioral health. Whenever you need guidance, CalMAP is your trusted partner in delivering confident, culturally responsive, compassionate, and evidence-based care to children, youth, and families.
CalMAP has been monumental in terms of access and elevating a family's priorities and their ability to receive care from an equitable and fair place.
Having CalMAP as a resource, knowing that it exists, that I can always go to that website, find those provider resources that have helped me in the past. When a challenging case comes up in clinic, I know they're only a phone call away or an e-consult away. It just gives me more comfort in walking into that clinical space when you never know what concerns are going to come up.
And so CalMAP is just open the door. I can just call the number and it will be on the phone with a psychiatrist. There's so many ways in which they can help us to kind of open the doors up to access for families who traditionally wouldn't have been able to access it.
We go. So here are here's the title, and I think we introduced ourselves. Here are our planners for this session, and then disclosures. So we're funded through the Department of Healthcare Services as part of the Children and Youth Behavioral Health Initiative through DHCS, and then we also receive federal Health Resources and Services Administration funding. as you can see here. And so we want to talk about anxiety. And I think as we think about, the high prevalence of mental health disorders and the, workforce shortage and the real challenges in connecting to the right care at the right time and by the right type of clinician, we need to think about what is the usual kind of age of onset. And, there are common statistics that get floated around. Half of mental illness onsets by age 14, 75% by age 24. So those of us working with youth are really in the, frontline place to be able to identify and begin to address some of those challenges so that it helps to kind of set a child's life trajectory up on the right path, as Joanne had mentioned in the video. So you can see here anxiety, really is when there's a strong kind of biological component to it, which there usually is. It is kind of there from, day one. And you can see this in younger kids, really young children. They're the ones who are kind of slower to warm up to new situations. They might feel more anxious in the face of new stimulus. And then anxiety can kind of, peak and then kind of come up again at different ages, depending on where someone's at in their development. And it's often comorbid with kind of later in life onset of depression. So anxiety can also, look like a lot of different things. There's kind of the tip of the iceberg is what we see and what we can observe a little bit more objectively, but it often kind of, belies like how someone might be feeling underneath that, how they're thinking about themselves, and, even deeper than that, kind of their identity, feeling like they've got good self-esteem. So, anxiety can manifest as anger. If you think about kind of that fight flight reflex, it can manifest as, I'm going to fight and really, having temper tantrums, maybe yelling as people get older. Also avoidance. That's a really telltale sign of anxiety. And again, that fight flight. So that's the flight part of it. I don't want to do this. This makes me so uncomfortable. So I'm going to avoid it. And it can look like lack of focus. It can also show up physically as insomnia and also fatigue. And with that, so we all have stress in our lives for a reason. I think we wouldn't get out of bed otherwise. So there's a healthy amount of stress that really motivates us. And as you can see from this diagram here, that actually was developed in 1908. If we have enough kind of activation, it evokes our attention and our interest, and we engage so we can have kind of optimal performance. But when the stress level becomes too high, or when our internal response to that with anxiety becomes overwhelming, then it actually causes kind of a decrease in functioning and leads to that kind of shutdown and not being able to perform. So the key is, thinking about anxiety as a normal feeling, but then, what is kind of clinically impactful? Is this developmentally appropriate, right? There's a difference between, being kind of anxious in the dark versus not being able to sleep at all, or, really, needing to come into parents' room every night and really having a hard time falling asleep, even with that. So you have to look at the overall functioning, socially, is it impacting anything in terms of school? And then always, with families. And then how much ability does a youth have to recover easily? How much time do they spend kind of worrying about this scary thing happening again, or worrying about a worst case scenario that is unlikely to happen? So looking at the 4 Ds of dysfunction, distress, duration, and deviation from a usual kind of expected developmental trajectory. And so these are some screening tools that you can use. And I'm going to pass the mic over to Shelly.
All right. So I'm curious, how many people actually screen for anxiety in their clinic settings? And if you do, which screening tool do you typically use? So if you wouldn't mind, and it could just be a clinical questions too. If you wouldn't mind putting in the chat, that would be just great information. But these are the typical screening tools that most settings use, the GAD-7, but and that's validated for youth 11 and older. And then there's the scared, which is 8 to 18, and the RCADS 3 to 12. What's unique about the scared and the RCADS is there's one for the parent and the child. And the reasoning for that is because often maybe the parent can see it, but the child has no knowledge of it, or the child may really feel it and they can sense it and they'll write high levels here, but the parent doesn't have any knowledge of it. They just see that tip of the iceberg of anger and irritability and reactive behaviors. So what's also cool about the scared and the RCADS is it kind of gives you a guide for maybe giving you what is separation versus generalized panic and social. And then again, these are just guides to help us dig up more questions that could be around what's going on for them. Thanks, everyone. Everyone seems to use the GAD or scared. Sometimes with the scared and the GAD is like, it's kind of hard to score them. But there are cool Excel spreadsheets out there that score it for you. And then I take a picture of that and I put it in my chart. So, or I have my, mentee score them for me as practice. So the other one that is listed, if there is concern of trauma, is the pediatric trauma symptom screening tool. Then there's one for the age group of 6 to 10, and there's one for 11 and older. I don't know if any of you have seen this rating scale, but it kind of goes through the symptoms of trauma. So like nightmares, hypervigilance, or like kind of like disassociating kind of symptoms. They are all in there in kid-friendly language to be completed. This is different from like the pearls or aces because they talk about something that has happened that's negative, but this is how does it impact you? How is it impacting symptom wise? So if you suspect some trauma, it's a great tool to use. I actually use that screening tool when I also have ADHD and there's a history of trauma. I will compare those two together. And sometimes even when there's depression and there's trauma, I will also use, the PHQ-9 and this pediatric trauma symptom screening tool just to give me a different understanding of the bigger picture to help me guide more questions. Yes, I love Excel tools. And so what is going to be our treatment plan when we come back with these scores and with our clinical discussions with them and their functional impairment? How do we figure out what we're going to do for mild, medium, and high? Okay. And I'm curious, what do you all use currently in your setting? Like, do you have an algorithm or do you guys have like a procedure that you use to kind of guide you and what you're going to do next, as far as if it's this, we do this, if it's that, we do that. These are our tools that we have to give for just education. Do you guys have those already in your clinic setting? If not, you could check out CalMap because they have a lot of these up and running. But we always love to hear more about this so we can help improve and add to it. So, it's interesting. Is the AAP had guidelines for depression, right? But they didn't necessarily have. There's information about anxiety, but there wasn't like the protocol, the procedure that you could follow. So, this is kind of based on the most evidence and clinical information we find. This is what we created here, which is, yes, use your rating scales in your clinical assessment, but we want to add in a safety check. Is there a history of trauma? Is there any suicidal thinking? Is there any self-harming behaviors? Is there any other risk factors around safety and concerns? And then, we always want to rule out other things that could be going on. Is there substance use, right? Is there a sleeping problem? And what other co-occurring things could be happening? We're not going to go into detail about the DSM-5 criteria, but it pretty much follows the GAD-7s. And but if they're mild, we're going to do anxiety education and hopefully refer them to cognitive behavior therapy if available. But we know finding a therapist is very difficult. So it's, even if you have commercial insurance, it's still very difficult. It's just outright difficult. So when we say, oh, you must have CBT, I like to say, you want to find a therapist that works with you that can help build coping skills. Most therapists have some knowledge and use a variety of different tools, including CBT. And then, if it's mild and like you're not able to get into a therapist, but it's getting significantly worse and they're having more impairment in function, and when do you consider starting an SSRI? And I think that is possible, and we'll get to SSRIs next. So when it's more moderate, anxiety, of course, you're starting with education and the therapy, and then you would consider SSRI treatment. Anytime, we'll go through about treatment with the meds last, but if it's high, you, of course, maybe you start sooner with the SSRI, and then we'll talk about that next. Okay. Did I miss anything, Petra? It's late in the day.
That was great. And there's kind of more, the thinking has been for so long that, that you wait to start meds and you have to have an adequate trial of therapy first. And like Shelly said, the practicality of that is just often so challenging. And the newer thinking around this is that, if the anxiety is really clinically impairing and you have kind of a good history or, a reasonable case for there's a strong biological component. And just because this person is just now presenting with you, you look back and there's a long history of maybe that kind of like of, avoidance and behavioral inhibition and shyness and maybe, separation anxiety and phobias and, all that were not like super, high clinical threshold criteria, but, still you see this pattern. That is just, speaks to biological drivers for this, especially if there's a family history. There's almost always a family history. And so then, you can be kind of more sure in thinking about a medication to treat that biological component.
So, one of the things is, how do we explain anxiety to a young person and to family members? And there's different types of ways of doing this that people use to make it appropriate to youth. Do you all have any? Oh, okay. I'll make it less interactive because we want to spend more time to ask more questions and consult questions. So move forward, Petra. Yes.
My
All right.
fingers are twitchy.
All right. So we want to normalize anxiety, and we want to say it helps us do the things we need to do. There's great, tools now with Inside Out, and the other part about anxiety is like the wave. This is that emotions go up, but they do go down, right? We don't always stay mad, and then it will go down at some point. So it's kind of riding the emotion wave. And we want to help kids identify their emotions. And we can do that by role modeling as parents and talking about it and how we dealt with our anxiety. So that's one way. Next slide. But how do we get specific to anxiety is often people will use like, how you have a smoke alarm to tell you that there's a fire. Well, our brain has a smoke alarm too. And so when we see something dangerous, it kind of goes off. But when somebody has when there's a lot of anxiety, or when in that part in our brain, it becomes too sensitive, it's always going off, even when there's not real danger happening. So that's one way of explaining it. And if any of you have other ways of explaining it, please put it in the chat that has, that things have gone well and how you say it to families. Okay. There's always the Dan Siegel fight, flight, or freeze response when your frontal lobe goes offline, and then you're just all emotion. That's what we often see too. Next slide. The other part. Oh, you're gonna say this.
No, go ahead.
Oh no, this is all you. This is your slide.
I know, but you were gonna say something else.
Oh, I was gonna say that part of the clinical assessment of anxiety is trying to understand the ABCs, which is what is the antecedent before you see the behavior, and what happens afterwards, the consequence. Because parents may just see anger, 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 but what is happening before they're angry is that, something's being taken away from them. So then they get like really upset and they slam the door. And all they see is defiance, and maybe in the but really what it might be is like they're really anxious that they're not going to get what they need. They're not going to get their needs met. And so the underlying thing could be anxiety. So tracking these behaviors and getting a full clinical assessment helps us kind of figure out, is this ADHD, anxiety, depression? We want all that.
Yeah. Yeah. I mean, I like how you said that. And I think, sometimes, especially parents, but, also just the environment in general. So like teachers and other people interacting can kind of, unintentionally, but actually like reinforce the anxiety because they allow, for some amount of avoidance, or they allow for, the irritability and the anger. And then that just kind of reinforces it. And one of the key parts of therapy, to treat anxiety is actually exposing yourself to that situation that is so feared. And in that process, even though it's super scary and hard to get someone motivated to do it, that, once they realize, oh, I can survive this, and with that kind of recognize like this isn't as scary as I had thought it was in my mind. So we thought it was a great coup that we got the video going at the beginning, but we were not able to make the video work for this. This is the game of whack-a-mole, for folks who are familiar with that. Basically, when anxiety is really biologically driven, it often can show up in different ways at different ages. And so, sometimes when you kind of just change like one particular situation or problem solve around that, then it can show up in a different way. You see this really kind of a lot with OCD in particular, like, okay, I stopped organizing, all of the papers and files, but now I'm going to go do something else that's kind of, compulsive and with a lot of checking. And so anxiety can show up like this. And of course, the first step in all of this, as it is with most anything, is that healthy activities and, nutrition, sleep, this is such an important part of screening and assessment, as we all know. And it's also really easy to give advice on it, and it's much harder to do it. But, we know that exercise especially is profoundly helpful in kind of helping to have that fight flight activation, have a physical release, because if you think about where that fight flight comes from, it's, our primitive brain saying, oh my God, there's a lion that's about to get you. You better run, or you better play dead, or you better run away, like, or, whatever you can do to fight it. And your heart's pounding and you have all of that kind of physical activation. And then if you just kind of sit there and don't do anything with it, our bodies are very activated without a release. So exercise is a great way to have that kind of simulation of running away from the lion, for example, to help get over that stress response. And of course, like caffeine, things like that, that are playing a role or could be playing a role. And then, illicit medications, you want to screen for those kinds of things. And then the behavioral approaches to this and kind of helping parents, like with their very best of intentions, and maybe, feeling guilty and like wanting to protect their child from anything that feels uncomfortable, how they might be that unintentional kind of reinforcement. And so helping them learn strategies for like facing your fears in a scaffolded way. And and then, of course, if necessary, looking at school accommodations, but not avoidance. We don't want to kind of perpetuate the avoidance, because the longer the avoidance happens, the longer it's going to continue. And it just reinforces that, yes, um, school is an uncomfortable, anxiety producing place for me because maybe I have an undiagnosed learning challenge, or, maybe I can't speak up to that peer who's been giving me a hard time and I haven't wanted to share about it. So, those are appropriate, but again, let's not kind of reinforce the avoidance. Here's some resources that we have listed on the CalMAP website. These are really helpful. Some are intended for kids, what to do when you worry too much. This whole series is really great for, different aspects of, like this is for more generalized anxiety. There's also one for OCD and other types of anxiety. And then helping your anxious child is really helpful. And then our partners, Luna and Bright Life Kids. Project Empower is kind of a self-guided therapy tool. And then also Coping Cat is one that has been around forever and really kind of follows a basic CBT module and is really helpful. So I don't know how many folks are familiar with cognitive behavioral therapy. I feel like, people tend to know a lot about it, but just in case, we'll cover some of the basics here. So this started off in the late 60s, thinking about kind of how our thoughts, feelings, and behaviors are all related. And that was, a triangle. And then somewhere along the way, we ended up adding in also sensations. And the idea is that these all impact one another. And the thing that we really have no direct control over is our feelings. We can suppress them or, shunt them into other types of feelings or behaviors, but we really can't directly control our feelings. And it's important to be able to manage the other, aspects of impact on feelings. Like, for example, if I'm hungry or tired, I know I'm going to be much more irritable. I'm going to be easier to anger. I might, feel more down, and then I get something to eat, and then I, feel better. I can focus again. Also, kind of on the outside, like what is happening. Some people are more sensitive to, for example, certain types of noises, lights, being in a lot of, a crowded place. So, the problem solving things that you can do are eat before you go, or try to work on sleep, change the environment, understanding I don't do well in crowds, so I'm not going to go to the parade when, I know it's going to be really crowded. Thoughts are things that, we can have kind of anxiety inducing thoughts because it's protective. It helps us kind of stay cautious. Like, I better set 3 alarms, to make sure that I get up on time tomorrow, because I don't want to oversleep. So these thoughts that we have, they're kind of, helping us to get through situations, but they can also get on overdrive. And so a way to mitigate that is through kind of challenging, is that a rational thought, or is that my anxiety talking? And then mindfulness can be really, really helpful in this. Behavioral skills, as Shelly was saying, getting activated, getting motivated, really scaffolding. For example, somebody who has school avoidance, you might kind of start with baby steps, just going to the school, and then maybe spending a little bit more time in a small place, etc. And then in terms of emotion regulation, just naming them, being able to share them with other people, is really can just kind of bring a feeling right down. Another is improving kind of tolerance for distress. And it's also important to include family in this whenever possible. So, we've talked through kind of the more like, education level interventions and active monitoring. And then we've talked through some of the most commonly used psychotherapy modalities to address this. And then the question is, when do we think about medication? And so, when to prescribe in primary care. And it's when, there's a progression of anxiety, as Shelly was saying, if there is significant impairment, if, sometimes youth are not even able to engage in any of those exposure or activation parts of cognitive behavioral therapy, and they just can't even fathom, like, there's no way I'm going to do that. So that is a signal. And And then really importantly, the parent and the patient can buy into this. And again, centering them at the heart of this, the main goal is for you to feel better, for you to feel healthy, and to engage in all of the things that, that are expected of you and that you love doing right now. And to think about, the cultural considerations, the family's expectations, and try and help educate enough around, both perceptions and maybe, things that are a little bit more myth, and then also how you're going to partner with them. Another is, know the patient. Sometimes, covering kind of the emergency room or like urgent care, you can be asked like, oh, can you just start an SSRI? Or, we have patients come through for an outpatient appointment and, they're just so, really wanting to walk away with a prescription at the very first, moment. And medications, usually SSRIs, if you're not taking them consistently, then they can actually potentially cause kind of more dysregulation. So you want to be able to, trust that they're going to come back and that they're going to be consistent and that you can monitor. And then, of course, being able to consult and collaborate with other care team members, especially therapists and other providers. So this is a lovely slide that Shelly created. And so I'll just walk through and she's going to jump in with anything additional. But, when do you think about medications? Really, it's, when we get to this point of all that we've just described. And also you want to just start with one, keep things simple, and then, go slowly. And I really like to go with, kind of half of what you would expect a normal dose to be, because especially in the beginning, you want to make sure that there's buy-in, that they don't have side effects, and then, you can kind of optimize based on responses. And the things that you consider are really like, what are the target symptoms? What's actually evidence-based, which is different than FDA approved. And then how old is the child? What is your real working diagnosis? Anxiety is often comorbid with, one or more other conditions. So making sure that you've got kind of the right diagnosis. And then, of course, substances and other medications that they're taking. And then we want to think about, the interaction with these other areas. Medications can potentially impact, pain levels. Importantly, we're going to come back to the suicidality piece and the FDA warning because I know that causes a lot of anxiety for all of us. And then importantly, the FDA approved versus off-label. So most medications that are used under 18 are not FDA approved. And the reason for that is because when drug companies go about, marketing the brand name when it first is released, it is so much more difficult to get things tested in kids, as you might imagine. So there have been a few medications that are FDA approved, but the majority are prescribed off-label. And then, of course, other things to consider, like what's covered by insurance, and then also like what are you comfortable with and familiar with. And sometimes also, what the family has, like other family members may have felt helpful. So here are kind of the main ones that, we tend to use more often in child psych. And as you can see, the FDA approvals for these are pretty limited. But SSRIs all have a similar mechanism of action, and they all, work. And some people respond to, multiple ones. Some people might have some side effects with one, but not another. Some general characteristics. So fluoxetine or Prozac is nice when you're a little bit concerned about consistent adherence, because the half-life is so long that it can, kind of self-taper, and you don't have really uneven, like increase in blood level and then decrease if you don't take it the next day. Most of the other SSRIs have about a 1 day, like 24 to 30 hour half-life. So if you miss more than one dose, then you might see some withdrawal symptoms. So, those Lexapro and Zoloft can definitely, have a little bit more withdrawal if you miss some. Um, Lexapro is really helpful, and some people find it a little bit sedating. So if you're hearing that, then it may be a consideration to switch to either Zoloft or Prozac. Prozac tends to be a little bit more serotonergic, and with that, a little bit more activating. And sometimes that's really helpful. Sometimes it's too activating. Zoloft has this indication for OCD in people older than 6 years old. And this tends to be the go-to for younger kids, especially because it doesn't have a super long half-life. It's really nice for anxiety. It tends to be, fairly well tolerated. And I think the main thing is if someone's getting, overly tired from it. In terms of improvements, so I really like to explain, that this isn't going to be a magic pill that suddenly your anxiety is better on the first day of taking it. However, there's the standard kind of 4 to 6 weeks of improvement or time to take effect for depression. But if you increase those serotonin levels, you can start to impact anxiety sooner. So I've definitely seen young people who, maybe a week into taking an SSRI, that they really feel like their anxiety is noticeably better. Um, Another key thing is that, it's not addictive. It's not going to change your personality. It's meant to help you function better. And I try to, engage young people in, can you think of a time when this anxiety didn't bother you or didn't kind of take up, so much time in your life? And then, ask them to kind of think about that time. And that's what we're trying to help you get back to. Um, Not everybody responds to these meds, and some people will respond to one and not another. So it's important to kind of continue to monitor. And in terms of side effects, the most common are GI side effects, which really are mitigated with like a really small dose and also taking it with some food. So sometimes, young people say, oh, I never eat breakfast, or I don't have time. It's hit and miss. So if that's the case, then dinner is usually the most reliable meal for people. So taking it with dinner. Headaches, these usually resolve fairly quickly and may be related to some of the GI stuff, so making sure you're drinking water, all of that. Changes in sleep, I think, that may, if it's prolonged, that may warrant a change in medication. Sexual side effects are common, and it's something that, people who train pediatrically, don't always kind of immediately, ask about. And I think it's important. And, sometimes young people are reluctant to kind of bring that up on their own. Um, Another thing is, that emotional blunting or feeling kind of numb. Like people say, oh, well, my anxiety is better, and my sadness is better, but actually I don't cry anymore. I don't feel joy. I don't feel anything. That's a sign that the medication is too high. And some of these less common side effects we're going to cover a little bit more. The bleeding part is a less common side effect that can happen, that may show up as like easier to bruise, or like if someone gets a cut that, it bleeds for longer. And the reason for that is platelets don't aggregate as well with the SSRIs, and it impacts some people more than others. Um, Here's some other medications that are often used for anxiety, but I really want to underscore SSRIs are usually kind of the main one, with therapy. And you can consider other medications. Hydroxyzine is an antihistamine that is used, somewhat commonly as a PRN. Um, I I like to think about PRNs as a signal, like what else is going on, and should we be on a longer term preventative medication? Because the psychology of a PRN, you think about the like take a chill pill, right? Relax, and it just sets up an uncomfortable dynamic with caregivers, and it's really it's much more ideal to have more prevention in place. That said, propranolol can be great for public speaking for people who feel uncomfortable, get nervous, that increased heart rate. People really find that it helps them to focus and center, and it dampens that fight flight response. And then benzos, really, we want to avoid them in general. They work on the same receptors, the GABA receptors, as alcohol. And, people sometimes use them in advance of procedures to be able to just get over that overwhelming amount of anxiety. But otherwise, we really want to avoid them. And this is one where, especially Xanax, Valium, cross the blood-brain barrier very quickly, very high potential for addiction.
I wanted to say another one that I put in the chat, which is duloxetine or Cymbalta, is FDA approved for 7 and older for generalized anxiety. But in general, our approach always is try one SSRI first. That doesn't work, switch to another SSRI before we would just jump straight to duloxetine. And another one we didn't list too, but we would use maybe in child psychiatry is mirtazapine, which is for adults, but it treats anxiety, increases appetite, and it's very effective for sleep. And it has less like GI side effect issues. So those are just some other alternatives that you might see or hear that we might recommend if you tried both SSRIs and you're not getting any response.
Thank you so much for flagging that. And duloxetine is approved, down to age 7, and the SNRIs, while they can be really helpful, more powerful in some cases than SSRIs, the younger the child, the more prone they are to having side effects from both SSRIs and SNRIs, including irritability, activation. So, like Shelly was saying that, try 2 SSRIs first. And this is one of those cases where even though it's FDA approved, it may not be the best first or second choice. So this is something that I personally feel like I see quite a lot of. And this is what has, every time that I feel inclined to start with, 20 milligrams of Zoloft of Prozac instead of 10, or, really go like quickly up to 50 on the Zoloft, I am reminded that people really feel activation. And in some studies, it happens in up to 50% of people who take SSRIs. I've seen a few times where it's very, very severe after even just 1 dose, and it's scary. So, really kind of thinking through like what has helped one other family member, that might be a helpful signal in terms of genetics, but it's not going to be predictive. And this really speaks to the importance of, good education around this whenever you're starting something. So SSRI activation is because of sudden rapid increases in serotonin levels. And the younger the child, the more vulnerable they may be to this. So it shows up in a few different domains, and it usually shows up fairly quickly after starting. So akathisia is one that we see a lot of, like general restlessness, needing to pace, or maybe, new foot tapping or something like that. And it's something that is easy to miss. It's easier for family members to miss. Disinhibition, this can look a little bit more like, just kind of being loose and goofy, or maybe like kind of inappropriately, like, sexual, behavior that that can happen in pre-pubertal kids too. Want to be really careful to distinguish this from manic activation. It looks like mania, but it usually happens just in the beginning of treatment. And there is this instrument, the TSAP, that you can use to assess for the levels of activation. And in terms of management, the recommendations are to decrease it, or to switch to an extended release formulation or a different SSRI. Honestly, from what I've seen and experienced, I think decreasing the dose can sometimes work, but then you're caught in, I can only do this low dose. And, the parents have gotten freaked out about the response. So usually end up stopping it unless there's already a proven, like really great response to, the depression and anxiety. And if that's the case, then you can add in beta blockers. So, activation, again, happens in these first few days to weeks and after increasing doses. It's not a change in mood, with kind of this constant elevated like elation that you see in mania or hypomania. But you do have these other physical, signs of restlessness, and it is not related to someone's chances of developing bipolar disorder. In contrast, bipolar switching is something that usually happens later in treatment, and it may not go away after you stop the medication. So this is where good family history, and asking about, bipolar disorder and family members, because you usually present first with depression, who then may go on to develop true bipolar disorder. And of course, if that's the case, they would need different medications. Um, questions that we get asked with some frequency is, this going to turn my kid into a zombie, or is it going to change their personality, or, have some control over them? People have a lot of beliefs about psych medication, and ascribe a lot of power to it or dismiss it entirely. But it's important to just kind of come back to that, like, I have the same goal as you. We, all want, so-and-so to be feeling better, and to get back to how they felt, in those times of feeling good, motivated, and engaged. And it shouldn't change their personality. And if any of that happens, we're here to work together to modify the treatment plan. So please let me know if you have any concerns. And then, there is this risk around suicidal thinking that was issued by the FDA in 2004 around increased risk of suicidal ideation. It's really important to be clear that this was an increased risk from 3.8% with the medication to less than 2% without the medication. So higher, yes, but really, substantial, no. And, also since that time, as you might imagine, rates of prescribing by primary care providers who are on the front lines, they felt less comfortable, prescribed less. And, at the same time, rates of youth depression and suicide have increased a lot. And so the goal is obviously to feel better, not worse. So here's a little bit more around, the suicide risk. This last bullet point is something I really emphasize, that the risk is highest in the first 9, 10 days, 2 weeks of treatment, and is more likely with higher than usual starting doses. And then the kind of timeframes that we really look at are like first 10 days of treatment, the first month, and then the first 3 months. And then once you get past that, unless you're making major, dose changes, it's unlikely that it's related to the medication. Again, this is kind of linked to that activation with those high increases in serotonin levels. Cross tapering is something, that when you're switching, the idea is you can choose kind of one of two pathways. One is to substitute a different SSRI at roughly the same dose of the previous SSRI, or you can kind of lower the first SSRI dose slowly over a period of 4 to 6 weeks while you're starting a new SSRI. And the key is that you don't want to get higher than the previous dose too quickly. Again, that 4 to 6 week kind of up taper. And from my perspective, I've always had much more success with the second strategy. The first strategy I've had backfire, and I generally don't use it. And then this is just a note about Prozac, because the half-life is about a week. So you want to let that wash out a little bit longer. This is important. How long should treatment last? People, sometimes feel like, okay, this is kind of like an ear infection or a sore throat where I take the antibiotic and I might stop it after I start feeling better. And with this, you really, our brains are learning organisms. They're always eager to form new patterns and habits. And so the idea with taking an SSRI is that you kind of, retrain your brain, your body into a lower anxiety state that is capable of engaging in all the things that are expected in life, and to kind of relearn, some of that feeling state. So the recommendation is to, keep it consistent for at least 6, if not 12 months after the symptoms really improve. And then, also to keep in mind, practically speaking, like, I've had some high school seniors say, oh, I just want to get off of this. It worked great and it got me through high school, but now I'm going to be going to college. And I really try to work with them to, especially if I think there's a strong biological component to this and family history. Okay, that's great. And I want to support your growing independence and maybe, spring of your senior year, like if you really want to do it, we can try coming off, but we got to stay in touch and, see how you're feeling because starting college is a ton of new stress and excitement, and the risk of recurrence, is significant. So just really being thoughtful about the timing. Um, and this is just kind of what can happen if somebody abruptly stops their medication. It can feel like the flu. The sensory disturbances, people talk about feeling kind of zaps, like a little bit of like electrical pulse, like in their limbs, nausea, insomnia, and hyperarousal. And this, I'm going to pass it to Joanne. And we also want to invite questions.
Joanne, you're on mute.
Oh, my Zoom just froze on me. Sorry. So thank you so much for this great talk. Before we go to announcements, I want to open up for questions. And so one question did come up, and I think it's really worth like getting like a verbal explanation out loud. How long do you wait for a response to medication, and do you wait a full 4 to 6 weeks? And here I would love to hear a response that talks about not just like, are you going to switch medication? When do you think about going up, and how far up do you go? So I'd love to hear some thoughts there.
Well, I kind of put in the chat that I want to first make sure we're at the optimal dose.
Yes.
So, and if we're at the optimal dose and you've been doing this for 4 to 6 weeks and you're not seeing any improvements, and I would consider switching.
And what do you consider an optimal dose? Like
The
if you're
maximum
saying
dose.
the
Without,
maximum
yeah.
dose.
If
Okay.
I can't keep go up because there's side effects,
Mhm.
then I'm gonna also switch to something else too. But I'm also checking, are they taking it every day? Are there other stressful things going on? Are they using substances? How's their sleep? Are they eating well? Can we utilize therapy more too? So it's multifactorial, but just that's how I approach it. Petra, anything different?
No, I agree. And I guess, I mean, people will really tell you, I feel some response, and I mean, we all know our own bodies best. And so I take that as a really strong indicator and signal like, okay, you are going to respond to this medication or you're not. And so that one is, if there's been a partial response, then I try to look at some of the other factors that Shelly was describing and see like, can you tolerate a higher dose? Generally, anxiety requires a higher SSRI dose than an antidepressant dose. And and so just to keep that in mind. But I really, am very cautious about kind of this numbing experience because that is, not the goal. And it can really turn someone off to the medication too. So, I mean, you want them to have a full kind of rich emotional life that is, with less anxiety, less depression, but, not being numb.
Absolutely. And along those lines, how long do you wait before you titrate to that maximum dose? How much time are you giving in between each step?
I'm waiting for you, Petra. You go first this time.
Well, I think, yeah, I mean, this is great. This is kind of fun, like a panel style, because I mean, we know each other's practice styles some too, having worked together. And I might go a little bit more slowly, with this, with the time in between. The key though is really, using rating scales to assess progress. And I appreciate like primary care visits are so short. I just full, like, just hats off how much, people do in a short amount of time. I do try to ask about some of the screening questions just to hear someone's response, because it could be that like the parent filled it out last time and now they're responding and their way of responding is really different. And you can kind of get a sense, is there like some, like some kids will say 3 out of 3 for everything on the PHQ-9 and the GAD-7. And they're sitting there smiling and, totally calm and happy. And then some kids will say zeros for everything, and you can just feel their anxiety or feel, their sadness in the room. So I think just looking at the whole picture is really key.
Right. And it's about their functional impairment and how much they're dealing with. Kind of helps me understand if I should be going up a little faster as long as they're not having side effects. And I have the luxury of doing like weekly visits and checking in with them for a good amount of time. Whereas in primary care, scheduling and making that happen, it could be very difficult. So in that case, the workflow is different. But I don't want this to be 6 months. I want to be able to get to an optimal doses, within the 4 to 6 weeks to try to figure out if this is working, so long as there's no side effects. I hope that answers the question.
Yes, and I often find that some kids are just more sensitive, and you're just going to go more carefully than others who just seem to need more faster.
I wanted to bring up one of the sensitive kids' natures. And very often, like when I first started, and it was FDA approval for kids with autism. If they were aggressive and disruptive, you started Abilify or Risperidol. And boy, did that work really well, but boy, did they gain a lot of weight. Okay, as I grew in my experience in time, I really started figuring out like what is the underlying issue behind these behaviors, and it was anxiety. And so we had an expert come in, and she really helped teach me, Melina Kaufman, like, okay, let's start with let's understand this behavior really well, and the pain of the picture is anxiety. And then we would do small doses of Lexapro, like 2.5. And that worked really well. I mean, I have to tell you, I have another kid on 1 milligram of Lexapro too. And it's working really well. So, and he has autism. So it's a sensitive one.
Yeah. I want to bring up like Petra's comments here. Anxiety is the great masquerader. It can look like many different things. And Petra, that you like 2 to 3 months as a titration period to get to where you're going to go. There's another great question that came through here that I'd love for us to talk about. What is your experience with screen time and anxiety, especially with teens? And do we have recommendations about best ways to have these conversations with teens and their families? So hand it off to both of you to see if you have any initial thoughts on that.
Well, we both have teenagers
who like their screens. And this is where it's great, to like not have you be a fly on the wall at my house. And rather, so, I mean, I think, back to the kind of basic biology of this, our bodies are not designed to be on screens for this much time as we are in, our especially like mid and post-COVID lives. And so we're not, we get a lot of activation, stimulation, the bright lights, the maybe video games that are, potentially violent. And that is a lot of, activation for our nervous systems. And meanwhile, our bodies are not doing that running away from the lion thing or exercising, to kind of get rid of that activation in a more natural way. And they're all, designed to kind of, keep our dopamine kind of going and, keep clicking and look at another, YouTube video and whatnot. And so it is a huge challenge. And, I mean, I welcome Joanne's thoughts on this too, because I know, I mean, the AP is kind of adjusted their long time, really well beloved to me, like screen time recommendations by age. And so I think, the biggest thing that we can do is motivational interviewing that that helps the young person to, develop a healthier relationship and self-regulation around it. And I say that, easily, and it's so hard to do. And I know that as a parent. And so, but I think like helping someone to self-regulate more with age, because once they leave the house, once they become an adult, if they don't have like the start of that self-regulation capability and kind of knowing what impact it has, then um, then that's even harder.
Yeah, I do want to point out that AAP actually published a new policy statement on this recently about media use in youth. And they went away from these hard and fast, like time limits. They said time limits aren't enough just because the ecosystem needs to change. It's designed to be addictive. And there's a lot more attention to what is this ecosystem and how do we advocate for something that's actually better because it's designed to overcome a lot of our sort of natural resistance. So that's part of it. But I want to point out the family media plan that they created, which is a great conversation starter. So it's less about here are the rules. It's much more about trying to prompt like a thoughtful reflection about what do we want from our screen time? What are the benefits we're getting from it? What is it crowding out? What are we not doing because we're spending so much time on our screens? And what are agreements that we have as a family for limits that we want to place on this. And some common limits would be we're not going to have screens at the dinner table, right? When we're having meals together, the screens are gone, they're off, or they go off like a certain time before your bedtime, right? So these need to turn off and charge outside your room. So these are common sorts of limits that are often recommended, but the media plan is a great way to get started with like encouraging families to have these conversations together because that conversation, because that thoughtful kind of reflection and then joint decision making tends to go over better, especially as kids get older. Uh, yes.
If others have ideas and tools, please share them. I could use them.
Yes.
But
Great.
I wanted to bring up another thing. I wrote a note. Um, oh, it's hard to get access to a therapist, and you're like, well, what do I do? Well,
Yes.
there is a free program, and it's like coaching, and it's called Soul Luna for 12 and older. It's an app that they can download that the California Department of Health offers, and then there's a Bright Life for kids, which is for parents, I believe, for the younger ones. So we should have that information for you all. But there is accessible coaching support that for mild anxiety you could use right away and refer them to that.
Two other things I'm turning to more. Clarity Pediatrics is this like statewide like parenting sort of like education program that developed for ADHD. But then they recently started offering what's called space therapy for anxiety. And space is different in that they don't work directly with the kids, but they actually work with the parents and they teach the parents how you do exposure, how you help your anxious kid. So the nice thing is that they take Medi-Cal and they take a lot of private insurance that are accessible throughout the state. So that's Clarity Pediatrics, and that's something that I've started using as I'm like waiting forever and ever and ever for actual like CBT and availability in communities. And the other one is Project Empower, because that's like 1 hour free parent training on how you do exposure therapy for your kids. So I think that came out of Schleider Labs, and I'll find the link and I'll get that in for you. And so I also want to point out that SSRIs, that exercise can be as effective as SSRIs for mood. Peter, do you want to talk about that a little bit more?
Oh, I mean, it's a more recent thing and it's more demonstrated impact on mood than it is for anxiety. But, I feel like sometimes we end up doing these big research studies that just prove what's really like, obvious and practical if you think about it. Just think about how your body feels when you're anxious, and then, how does it feel to even just take a quick walk or, to do something and some of the other coping strategies, talking, naming the feelings, etc., are just so helpful.
Yes. And so yes, here is the link for Clarity Pediatrics. Thank you, Anyanam, for finding it. But it's nice because they'll take provider referrals there as well. And the question is coming in from Shelly about how many in this group have had a chance to prescribe medications for anxiety or waded into doing a little therapy. So, yes. So I'll also say that kind of similarly to Shelly, I'm a general pediatrician, spent years and years at a fairly qualified health center, just doing just regular primary care. And I had not learned how to use SSRIs like when I was in my residency training because of that black box warning. But after I learned how to start SSRIs, I did find that some of those kids who were coming just like crying and saying, I'm falling apart and I need help now, or having panic attacks and not able to go to school without like their parents' benzos, right? That like the SSRIs made a huge difference for these kids. And so I needed to have a psychiatrist walk me through the first couple of times I did it because I was scared of that black box warning. I wanted to make sure I was doing it safely. And this is exactly what CalMAP is for. And so with that, I wanted to share a little bit more information about CalMAP. And while we're doing this, and you can go ahead and throw up the Zoom poll. We do more of that with this, in addition to this webinar and special webinars like this, we do webinars on a regular basis, and we have one coming up specifically on SSRIs if you want a deeper dive into this, as well as on cognitive behavioral therapy and some of the principles of cognitive behavioral therapy and CBT-based sort of like pearls that you can use, brief interventions that you can use in a brief office visit. So that's coming up soon. And you can see some of the other activities that are coming up as well. We have our primary care advanced echo coming up as well for folks who are interested in learning a little bit more about trauma, PTSD, disruptive behavior, substance abuse is on deck for that as well. And for those who are in school-based settings and want to like hear more about like how pediatric or youth mental health can be supported in schools, we have a school-based echo that happens on Mondays, third Mondays as well. And then kind of along the lines of like it being really helpful to have a psychiatrist walk you through the first couple times you might use this SSRI if you haven't done this a lot before. This is the phone number to call CalMAP. There at the bottom, there's also the QR code that you can scan to our website and look at all the resources that we have there. The CalMAP consultation line is open from 8:30 to 5 on Mondays through Fridays. And sometimes if you are charting after hours and it's long past 5 p.m., we also have the capacity to place e-consults on our platform, as well as schedule another callback time, say for your admin time or lunchtime on another day, if you want to have that phone conversation. So I want to make sure you have the number, you have our website, so you know how to call. And this is how you claim credit for today. So if you're having issues, we can drop the kind of a ticket system or like kind of a link where you can get help for claiming this credit, and any of them can help you out. And some of the instructions can also be found here in the chat. And yes, CalMAP definitely helps with ADHD medication prescribing as well. So not just the SSRIs, but also for ADHD meds, any other psychiatric meds, and a lot more than medications as well. Screening, diagnosis, treatment planning, long, like well past the meds as well. Yes. Yes, and we, as you are getting credit, we want to give a big shout out to Linda Mendoza for getting this rolling and for organizing this webinar and getting it started. So huge shout out to her and also to Kristen Nagarian, social worker and CalMAP care coordinator from CHOC, Children's Hospital Orange County. So huge thanks to the two of them for organizing this webinar, and also to our speakers, to Shelly and to Petra, for giving us this excellent talk today. So with that, we'll keep this up just a little bit longer for you to be able to claim credit. And in the meanwhile, hope everyone has a wonderful evening.
And I didn't catch all of the chat. I don't know if we put the link to register with CalMap into the chat. Did we do that? Let's see. A nod, yes. Also, if anyone wants to, stay on, I know some people may be signing off and it's late, and we just so appreciate you spending your evening with us. If you do have any, kind of specific consult questions that you'd like to discuss, we, will stay on for a little bit longer.
Thank you, Anuna, for dropping in the CalMap registration link into the chat. So it's there for anyone who wants to sign up. So they can start consulting.
Thank you. Big shout out to Anunam for keeping us all together. Really appreciate it.
Well, seeing no more questions, I think we can go ahead and close off for today. Thank you, everyone, for coming, and we hope to see you at a future CalMap event or calling in